Okay, I'm going to go ahead and get us started. Hello, and welcome to today's webinar, Enhancing Medicaid Equity Through Health Literacy, Practical Strategies. A couple of reminders, all lines are currently muted, and this event is being recorded and will be posted to chcs.org afterward. On the next slide, I will go over today's agenda. We'll be starting with welcoming and introductions. Next, we will have a grounding and overview of health literacy and its intersections with health equity work in Medicaid. Then we will have 3 panelist presentations on health literacy, health equity, and Medicaid emerging strategies and practices. This will be followed by a conversation and Q&A with panelists. And then we will conclude today's webinar and you will receive a survey to complete. We appreciate your feedback in advance. On the next slide, I'll go over a couple of brief points on the Center for Healthcare Strategies. CHCS is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to better ensure better and more equitable outcomes, particularly for children and adults in Medicaid. Since 1995, we have worked in every state in the nation, and we partner with state and federal agencies, health plans, providers, community-based organizations, and consumers to make healthcare work better for people who face serious barriers to well-being, barriers like poverty, complex health and social needs, and systemic racism. We work to advance more effective models for care delivery, more efficient policy and program design, and across all of our work, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity for people facing the greatest disparities. Next, I'd like to introduce today's speakers. My name is Vicki Quintana. I'm a Senior Program Officer at the Center for Healthcare Strategies, and I am joined by Shilpa Patel, Director of Population Health and Health Equity at the Center for Healthcare Strategies, as well as Isabel Bravo, member of Banner Health Plan's Member Advisory Committee in Arizona, Danielle Brooks, the Corporate Director of Health Equity at AmeriHealth Caritas, Yingjia Huang, Assistant Deputy Director of Healthcare Benefits and Eligibility at the California Department of Healthcare Services, and Colleen McGregor, Administrator of the Office of Individual and Family Affairs at Banner Health Plans in Arizona. And now I'm pleased to turn it over to Shilpa Patel.
Thanks, Vicki, and thank you all so much for joining us today. We're excited to hear from our panelists and dive into a productive conversation about how states, plans, community members, and really all of us can play a role in advancing health equity for individuals with Medicaid through health literacy practices and policies. To ground us, I'm first going to provide an overview of health literacy and how we at CHCS really see it as a lever for advancing health equity. We will be, citing some research and studies throughout the presentation, and most of this material, including the studies cited, can be found in our health literacy fact sheet series, and we'll share the link in the chat now and in a follow-up email as well. Next slide. So first, I wanted to offer a definition of health literacy, just given the broadness of the concept. It's both a term and a set of practices that has evolved over the years since its conception. While health literacy has historically focused on patients' understanding and fluency with health information, today health literacy is as much organizational as it is personal. On an individual level, we still want to empower patients and community members with as much information about their health, including their conditions, medications, behaviors, access, and coverage, as possible. But we also realize that health and healthcare are areas that grow increasingly complex day by day. That's why we like to describe health literacy as a two-way street. Healthcare organizations, including providers, health systems, payers, and state agencies, all have a responsibility to use effective communications practices to improve health literacy. Next slide, please. So one way asks why we are placing such a focus on health literacy. And, a lot of clinical and other research literature finds that greater health literacy is associated with improved health and wellness. When health literacy practices work, it means that individuals understand and can use the information the systems around them provide to improve their health and thrive. Improved health literacy can reduce medical error, increase utilization of preventative care services, improve chronic disease management, and is associated with reductions in morbidity and mortality. Next slide. Greater health literacy is also associated with a reduction in healthcare costs. For example, one study found that limited health literacy costs the economy up to $349 billion annually due to factors such as increased or inappropriate use of acute and emergency care, medical errors, miscommunication that leads to unnecessary or inappropriate interventions, and a lack of preventative care. Combined, these factors and others can contribute to worse health outcomes and higher costs for patients, payers, and the system overall. Next slide, please. Finally, greater health literacy can advance health equity. Low or limited health literacy is associated with poorer health outcomes and disparities in healthcare access and outcomes across categories like race, age, income level, education, and geography. Improved communication and health literacy practices between healthcare organizations and their patients, members, and communities can contribute to better health outcomes for all and reduce disparities for communities that have been historically marginalized. Next slide. At CHCS, we focus on people served by Medicaid, and limited health literacy can disproportionately impact individuals with Medicaid. State Medicaid agencies and plans, like the kinds our panelists today represent, serve large, diverse populations and are uniquely positioned to deploy innovative health literacy strategies to advance health equity at scale. And it's now my pleasure to introduce you to our first panel presentation from Banner Health. Colleen and Isabel, over to you.
Thank you very much. And good morning, everybody. We'll start with just introducing ourselves. And we have a few slides that we want to overview. And just to set the tone, we're incredibly hopeful for more of a how-to, if you will, in our presentation. So hopefully we meet the mark. Again, my name is Colleen McGregor. I oversee the Office of Individual and Family Affairs at Banner Health. And I am a person with lived experience, and we're a program of lived experience. And please allow me to have Isabel introduce herself.
Hello, my name is Isabel Bravo, and I am my role is a regional coordinator. I do the recruitment, retention, and training for the ambassadors for TLCR.
Thanks, Isabel. Next slide. Perfect. Thank you, Emily. So what we're hopeful to, we want to spend some time talking about some of the nuts and bolts, some of the policy and practice that drives our engagement strategy that allows us really to focus in on a very health literacy strategy and approach. We want to talk a little bit more about the hows, though, how we cultivate a supportive environment in support of rich health literacy, aligning, and this is probably where Isabel's really going to shine a light, is we're really unique in our approach and how we align member voice in shaping our policy and our practice within our plan. And then we want to share a little bit around some of our lessons learned and some things for folks to consider as they approach infusing member voice into their plans. Next slide. This is more of a formal process. We have an actual contract requirement at our plan. It is both a combination of our mission to make healthcare easier so life can be better coupled with some of our Medicaid contract requirements. And because of the intentionality around how we approach it, we've really been able to cultivate and foster robust representation across a total of 6 committees. I think we're growing, actually. Isabel probably will keep me more honest here. On average, we have 27 member and or family members. We call them committee ambassadors, sitting on a variety of committees, as you can see here. Our governance, which is critical in reporting up to our executive leadership, our CEO, our COO, and our CMO around strategic planning and decision-making for our plan. Our Member Advocacy Council, which is richly represented with membership and really drives a lot of our strategic initiatives that we can talk about a little bit later. We have representation on our cultural competency, which drives a state-approved cultural competency plan. A newly created health equity committee, which has a sub-work group looking specifically around health literacy practice. And then we have, because we are a health plan, a managed care organization that serves 10 counties, we also have local voice that is really captured in what we refer to as neighborhood advisory councils, which focus both on a provider side and a community side. And we've really seen amazing operational impact as a result of our approach, really having, I like to say, and this is just a point of, I think, shining the light on our plan because of our intentional approach is really impacting strategic planning and decision-making, creating a specific health literacy plan. And what we really have focused on are those 3 core areas of functional literacy, interactive and communicative literacy, and the critical health literacy around community and advocacy, and where we have really leveraged our membership. So as a program within inside a managed care organization of lived experience, we're charged with ensuring that member voice is heard. One of our areas of doing that is in our committee and council representation. And through that, we've been able to look at functional areas of literacy, how our members directly have input into informing member communication and print materials, interfacing directly, for instance, with our marketing teams, sitting on sub-work groups to inform member handbooks, for instance. The other piece that we've been really instrumental with our approach is in the development and implementation of things like a stigma initiative, and leveraging our committee ambassadors to inform another contract requirement around ensuring that our service environments within our network are trauma informed. And then one thing that I think has been probably closest to my heart and amazing to see is now that we have spent very deliberate time across our committee ambassadors, they're wanting to give back. And so regular surveying and engagements have gleaned an opportunity for our ambassadors, who often sit as credentialed or certified peer support specialists, are looking for opportunities to not only use their lived experience, but their enhancements around understanding service delivery and giving back to the community through educational campaigns. Many of them want to support prevention efforts in like our local schools and facilitating peer-driven substance use programming. So just amazing work, I think, that we're doing in those 3 functional areas. Next slide. And this is where Isabel and I are going to probably tag team. Want to set her up for success in some of the things that she almost innately does. And that is cultivating safe environments for authentic sharing. It's through our plan kind of approached the aspects of recruitment and retention and training on our committees and councils through a partnership with a local community-based peer-run organization to help us with that diversity of membership representation and really hearing from a diverse cross of our population that we serve to inform those things. And it's through that relationship that Isabel has taken a front seat around supporting our recruitment, our retention, and our training efforts with our committee ambassadors. Isabel, are you comfortable talking a little bit about how you engage folks, how you receive applications, how you screen them for us, how you bring back that information in our monthly check-ins? You want to speak a little bit about that?
Sure. Thank you, Colleen. Well, let me just mention before I begin that I'm very nervous, so excuse me. Never presented in a panel before, but yes, thank you. I'm very, very blessed to be a part of this, having the role of being the regional coordinator. The recruitment, I seek out individuals with lived experience to share their story. We also train them I also train them in how to effectively share their experiences, train them in their role and responsibilities as ambassadors, and how to effectively leverage their voices in the committee. I will collect an application with them, and then we will screen it. Me along with a couple of the and the OIFA team. And then they're accepted and they begin the process. We will do a training, an informal training, an informal training where ambassadors get to see their role in the monthly committees. I wrote down notes and my notes are all over the place, so I'm sorry.
It's okay, Isabel. Isabel, I think one of the really important things that's unique to our partnership and has really evolved, and I think one of the key pieces for us to understand is this is an evolution, right? So Isabel has had to navigate a very large health plans, culture, and climate around hearing feedback, hearing feedback from our plan leaders, and then taking it back and chunking it, breaking it down for groups of people. She basically manages a very large committee representation in Yuma. It fluctuates from anywhere from 10 to probably 15 individuals. And they have been instrumental in that bi-directional, right? That personal and organizational process. And she has very successfully not only cultivated their voice in giving us feedback on critical things within our plan, but simultaneously building their own individual literacy, their functionality, right? Reading and understanding, complex health plan information. But it's also afforded them an opportunity. Like Isabel, I'm still relishing from our oral health presentation, Dr. Nevado, interfacing directly with our dental director around, a very complicated topic around oral health, which is not comprehensive in Medicaid. And so they were able to speak from their own personal voice, but shape it from a system perspective. And that, quite honestly, that's all of Isabel's support. She leans into us monthly, right? We talk about, those monthly check-ins, but it's really Isabel courting these individuals, not only in their own personal development, but how they can effectively help us in building our own competencies around health literacy and all the materials and things that were required from an organizational perspective. And I did not mean to take that away from you. I was simply trying to support you. And with humble gratitude, Isabel doesn't see all the things that she does. So is there anything that you want to kind of add to that?
No, the only thing I would like to add is, the goal is, which is to empower the ambassadors to take an active role in managing their healthcare and navigating the services and just getting a basic understanding of their voices being heard. Thank you, Colleen.
Excellent. And I want to give a big shout out to Isabel because it was, she helps craft regular survey instruments to make sure that we're on point. Some of the ambassadors sit in meetings where they're more heavily reported out, and there may be specific questions that are asked for input, like the cultural competency plan that we were talking about. So we have an individual that sits there. He's not only building his own literacy around what that is, but he's also learning simultaneously and kind of like drinking from a hose as to, oh, I have an opportunity to actually inform this because I didn't feel at this point of care was really like culturally competent, or my ethnic beliefs weren't, heard, and that feedback has been able to be shared. The other piece where Isabel's been really paramount is expanding our health plan, health promotion and disease prevention options. We had a vendor come in, and this was a result of the MAC ambassadors saying they needed more information around managing their diabetes and access to healthy nutrition. And we partnered with Food Smart. It wasn't initially something that all of our membership had access to because of the voice of the MAC ambassadors and their ability to really articulate their needs, right? They advocated, and now it's been expanded to our entire plan. So anything else on that, Isabel, before we move on? I think we've talked a little bit about the internal plan, our committee and council. We do robust training.
Yes.
I think it's,
the
go ahead.
The agendas for the MAC meeting is very helpful to our ambassadors. I'd like to print it out for them so they have access to it. If they don't have their agenda, they ask for it, and pretty much I'll go over the agenda with them prior to our meeting, so they have an understanding of everything that's going to partake that day. They really enjoyed the presentation that we had on wellness. They absolutely enjoyed that stuff. So pretty much I try to break it down for them and then just run it by the team, and the team coordinates the rest. Thank you so much.
Yeah, of course. I think the other aspect to that is regular check-ins. So we have formal meetings with Isabel. We have monthly check-ins, but Isabel knows and understands and is really quite established across the plan. So if she has questions on behalf of the ambassador, she just reaches out to the committee chair or co-chair. And then that infusion into our training and our culture and climate building is so incredibly important. And I think that's all I'll say on this slide. We can go to the next slide. Yeah, and I think we already kind of touched on this, Isabel. This is kind of how, this is our how. So there's some formal things that you really need to get in place, I think, to build the momentum and the capacity to have this kind of bi-directional learning, sharing, and growing. We have the formal approaches with our marketing and communication folks, looking at regular check-ins around our member materials, our survey instruments. How are we in line with the class standards? We also have a requirement through our work plans. So there are some formalities that really cultivate and foster this kind of support. We also have the freedom within our member advocacy council to do independent work that then we push up into the plan, kind of like our stigma stops here and those prevention initiatives that we were talking about. I think one of the really important pieces to consider is, how do you leverage that lived experience within a managed care organization to really have formal impact around things like building literacy, building just knowledge building and understanding, so that the culture is open and receiving to those kinds of things. And then, the sky's really the limit. Isabel, was there anything that you wanted to add to this, infusing the voice?
Not at this moment, Colleen, thank you.
Yeah, and in defense, Isabel is getting over some yuck, so you may hear her a little bit getting over a virus. Next slide. I think this is where the return on investment really comes in. This is some contributions from our MAC ambassadors in an annualized survey, and it talks about, quite honestly, their gratitude. I think that's something that is felt deeply across all of our committee and council work, is the gratitude that they have to be a part of a solution and really leveraging where they were, because we've had exponential growth. I think that our folks on our MAC have grown individually, personally. Their capacity within their own health literacy has grown. And then the ability for them to leverage their voice for larger system improvement has really been paramount. And so, and I think where we have honestly had our success is that Isabel is in an area where we have strong membership, and her serving as a regional coordinator, us chunking out that role, working with that formality, that piece, has really aided us in taking a very intentional, deliberate approach around health literacy and that intersection to health equity. And we wouldn't be where we were, honestly, if it wasn't for the support of Isabel and the work that she does bringing that voice. But we just really wanted to kind of leave you with some of those qualitative pieces around individuals' experiences. Next slide. And I think we've talked about this a little bit throughout our presentation, but I think, and Isabel, correct me if I'm wrong, but preparation is really key. Isabel talked about the importance of front loading, having our agendas ready, having like I call it multimodal tools. Some folks learn better if all of the slides are presented ahead of time and they have an opportunity to familiarize themselves with the content. You're going to get much more robust participation. It also helps them check in on what their experience has been and allowing them to look at it from a systems perspective. That's quite honestly how we got a lot of our feedback around some of our collateral materials and have improved those. And I think that it's a constant, culture building opportunity, and the training and engagement has really been key for folks to be open to hearing. So how we've switched in making that information. Okay, we're going to move on. So sorry, I went over, I get passionate. In closing, if there's any questions, we have our contact information in the slide deck. Please do not hesitate to reach out. And thank you, Isabel.
Hello, everyone. Good afternoon. Again, I put in the chat, but Isabel, I am humbled to learn from you and all the wonderful work that you're doing. So thank you for your presence and time. To introduce myself, oh, no, please. Sorry. To introduce myself, my name is Danielle Brooks. I am the Corporate Director of Health Equity and actually Quality. So what that means is that my department of about 20 really operates to support health equity writ large, which includes access to language services. And so I'm here to talk a little bit about the foundational aspects of class, which I'm sure you all have heard of, but what does that actually mean? And how this is operationalized within a multi-stakeholder, multi-market environment. So a little bit about my company. AmeriHealth Caritas has been around for a long time. I won't give you the story. I would say we've been a bit in operation older than me. So let's say 40 plus years. And we operate, our main headquarters is in Philadelphia, but we are all over the nation, predominantly on the northeast, southeast, a little bit in the south, in the Midwest. And so as we look at what we do, we really are looking at language access, not just from a market specific area, but we are looking at it at the market specific area and those service areas, but also how is a big company like ours really handling and supporting the needs of our members and communities. So just by way of background, when we talk about class, that stands for culturally and linguistically appropriate services. It is a mouthful. But really what it does, and really what the tenets of this, as I would describe it, really create a system in which your activities, and I say end to end, because oftentimes when we talk about class, there's a connotation with health equity accreditation or quality practices. The way that we look at it and the way that we look at our practice of equity is end to end. So once a person hits our plan, how do we support their needs and equity and also whole person care from that moment to all the touch points? So class is that practice that recognizes that you really need to make sure that you are steeping your language access, not just at certain touch points, but throughout that connection with that person and that community in the system. Class recognizes that from a governance leader and workforce. So how are we training our associates in these activities? How are we looking at DEI purposefully and making sure that we're not only recruiting people that can be trained to learn, but know, because diversity is the strength, especially when it comes to language access. And I'll get about in that in a little bit more. And also, how can we actually have that designated role? So for our teams, though we are kind of spread out across the nation, we do have a dedicated person at each market level that really does handle these needs as it comes to language access and health literacy, among a lot of other functions. The communication aspect is really one of those really foundational principles within this paradigm, but it really not only looks at language assistance as meaning translation and interpretation, but how can we really make sure we're creating this environment so that language is thought about not just as an addition, but really a practical component for whole person care. And then, of course, continuous engagement, learning and improvement and accountability. So creating those checkpoints, those auditing, those understanding to make sure that we're not only just providing a service or we're staffed with people that can support language access, but we're continuing to make sure that we create an environment for that as best as possible. I do have some notes here. This is a standard piece of any health equity accreditation that you will touch, either health equity original, I call it, or health equity plus. But it really is more than that. And so we want to get a little bit more into that functionality in the next slide. So next slide, please. So when we talk about language access, I thought it was really important, and Shilpa stole some of my definitions, but that's okay. But we're really talking about that for individuals that have limited English proficiency, making sure they have reasonable access. But the way that AmeriHealth views that is beyond this definition. So this is kind of the basic table stakes definition of what you should have when you're thinking about language access. But the reality of that is that we really want to make sure that we take a look at language as not just a functional component, but it is a person, it is part of that person's being and how they communicate and live in the world. I always remind people that language is something you dream in. Language is something you feel in. Language is something you communicate in. And for anybody that is bilingual, you know that experience. And so when we think about language, again, I like to take it in our practice of AmeriHealth, it's not just that provision of services to add addition, it is thinking about all those systems throughout. What that looks like for AmeriHealth is a couple of things. So we purposely look to recruit bilingual staff, and we have our call center is fully staffed with bilingual associates. So what that means is that when somebody does connect with us, whether it be to schedule an appointment or to learn more about some of their medical needs, they do have the ability to interact with somebody at that point in time that speaks that language. And that is critical because there are things in dialect and slang in languages, and being able to have that point-to-point communication helps support that trust and helps provide the context to what is happening. The other thing we look at is our auditing. So we make sure that everybody we have staff has been certified through an external vendor. And we actually take time throughout the year, every year, to proctor language services, not only with our members in the communities, but also with our staff to make sure that as they see it, we are providing information and direct language services to our members, but also those that are speaking directly with our members are trained and certified. We also make sure that our providers and our members know that this is free to you. It is free to you. You have the right to access it. You have the right to go to a provider that speaks the language that you feel most comfortable with. So we take a lot of time to refine and continuously refine our practices of collecting data from our provider network, not just of that primary doctor at that office, but also the staff that are there. And really to make sure that we have ways to connect our members, and it's their choice to who they want to go to. And the data speaks to this. I did pull some data from Kaiser Family Foundation, but it's real and it makes sense, right? Those that do not have access to language services or are not able to go to a physician or provider network that has those services or someone that speaks that language directly have worse care. And that makes sense. Communication and understanding what is required of you for a medical condition and also being able to advocate for yourself is critical, not only to create trust, to reduce bias, to be able to have that advocacy and self-choice. So I really want to impart everybody on this call that let's flip the paradigm of it is a service, it is a right, is legally a right, but also it's imperative to create those networks and to break down those barriers. And the data speaks to that. We also know that federally, because health equity is inherently political, I apologize for saying that out loud, but it's true. And so as we look at what is being pushed at different state levels and different federal levels, there has been a concerted effort to really codify those access under the current administration. And that's over multiple policy areas and also in the strengthening of the 1557 privacy provision. All right, next slide, please. So when we think about this as well, health literacy and language access services are often sort of divorced in the conversation. And as you think about it and read about it academically, you typically see this strange divorcing of health literacy over here, language access over here. My argument is they're one and the same. It is about, again, that point of communication to provide that information to that person in the way that they would like to receive it. And so as we look at this work, we have to be very cognizant of that. There is the cultural relevance piece to make sure those translations actually make sense in the communication style, actually talk to communities in the way they prefer, and also makes it functional. I think sometimes in systems, it becomes very difficult when you have academic battling against, reality. And that's why I was so humbled by Isabel's work, just listening to actually breaking down. And that's exactly an example of how to harness your communities to really make sure that your information is actually getting to that person. And so similar to Banner's model, we have MAC meetings, member advisory councils. They're called different things at each of our plan, but they simply function the same way where we do receive that feedback. We do that not only from a linguistic standpoint, but also from an age standpoint. So we have youth focused advisory councils that also allow us to understand how can we provide information on critical pediatric needs in those youth populations, and really receive that information on how to make things accessible in that way. But when you're actually thinking about that, I want to impart a thinking about making it functional end to end. So think about your written, your alternative formats, how are you actually delivering the services? Are you choosing to use an interpreter? Are you making that decision to get bilingual staff? Are you making sure there's video, there's phone, there's accessible formats depending on the need? Making sure the information is reading level appropriate and real life applicable. We can talk about glucose all you want. That may not be how it's discussed in a community. So what does that actually mean? And how can that community way of talking about something and that medical way find a path together? And then also thinking about that intersectional lens. Just because you're LEP doesn't mean you don't have health literacy needs. Just because you're LEP doesn't mean you're health illiterate. So making sure you're thinking about this fully in those intersectional needs. And that's also a practice that we take at AmeriHealth Caritas. And then also thinking about, at the end of the day, we know that advocacy and being heard is one of the biggest challenges in breaking barriers in equity. You can look at it in maternal health, in chronic care conditions, in a lot of different formats. So again, we really want to make sure that what we're providing allows that two-way communication and really harnesses on the rights and ability of individuals to access their health and be a true participant in their health care. And I gave a guide from CMS that actually talks about developing an access plan, but these are the things that I really wanted to impart as important. With the AmeriHealth Caritas, we take these pieces. We do have the MAC committees. We also work very strongly with our provider networks to make sure that they know about the language services that are available, helping them get supportive third-party vendors if needed, and also educating on those components as well. And so we really look at this as this triad of involving the community, the member, the provider, and our internal resources to make sure that we are actually supporting that. So when you're thinking about class, again, that's the foundational look at this work. It sets sort of the tone and the framework, but it's really important to understand your community, the needs, and also not be afraid to readjust and be agile, because language is agile. When you collect LEP information from somebody, it's important to do that in frequent intervals because language changes as well. It's also important to think about structures. So there's a lot of emphasis on collecting language information, but look at it structurally. Are you collecting this from in a family situation where one individual may be LEP, one individual may have more language access? So how do you make that information digestible so everybody has equitable access to advocate for themselves? I believe that was my last slide, but I could be lying. So is there another slide? That's it. Thank you for the time.
Good morning, everyone, and maybe good afternoon where you are. Thank you, Danielle, and all my fellow panelists for all the profound pieces on health literacy. Nice seeing everybody here today. My name is Yingjia Huang. I'm the Assistant Deputy Director at the California Department of Healthcare Services, which is the California State Medicaid agency in California. I'm here to talk to you a little bit and share from kind of a government perspective on how our health literacy journey in California, and I'll be sharing an example of what we've done. Next slide, please. So in January of 22, we worked with California Healthcare Foundation, which is a huge foundation in the state of California, to really look at the way we communicate with individuals. California's Medicaid program is the largest in the United States. And we, at one point during the COVID-19 public health emergency, carried close to 16 million lives on our program. And it is so important as, you know, we are kind of developing correspondence to our Medi-Cal, we call Medicaid Medi-Cal in California. When we develop correspondence to our Medi-Cal members, that we know how to speak to the member. So during January of 22, we worked with California Healthcare Foundation, which looked at many of the existing correspondence in California's Medi-Cal program and provided a lot of actionable next steps for us. And it really is a way of looking at the member experience. You will hear me talk quite a bit about the member experience as all the Medicaid agencies across the United States are kind of coming out of the unwinding, which some of you may know that during the COVID-19 public health emergency, all Medicaid agencies paused an annual requirement, which is the redetermination requirement. As part of the Medicaid program, every single member household must go through a redetermination process to reevaluate your annual eligibility. During the pandemic, this was paused for 3 years, and there were no adverse actions taken on any individual. So during that time, as all the requirements were paused, we kind of took this as an opportunity to really look at certain things such as communications. And as I think all Medicaid agencies were coming out of the public health emergency, having to resume this redetermination policy. And for California, we resumed our annual requirements for this process on June 1st of 2023. It's a 12-month process for most states across the nation. We really use a lot of these communication or these actionable recommendations found in this plain and clear, making Medi-Cal communications easy to understand. We infused it in a lot of the work that we did. And as many of you may not come as a surprise with government correspondence, oftentimes, in this work, we found through focus group testing with our Medi-Cal members, we found that, many of our correspondents are frustrating for the member. They get confused at the terminology, the vernacular that we use, and it causes additional levels of stress for individuals. And I put some snapshots of kind of the notices that we usually will go out to our Medi-Cal members. And as you could tell, just by looking at this is definitely a government type of correspondence. And so we really took a lot of the recommendations in this report. And as we were developing the outreach strategy for the unwinding, which is just a term we've used, a term of art we've used in the Medicaid world to basically kind of describe the work when we are coming out of the public health emergency and resuming kind of the annual normal operations for the Medicaid program. Next slide, please. Into some of the graphics that you see on this slide. As you could tell, is a departure from some of the language that we often used in government correspondence. Not to say the documents that you just saw don't exist anymore, because those are federally required correspondence to our members. But there's a practical way of making it much more member friendly. And an example is the unwinding. And there's no better example for California than what we've just experienced. California, as we were exiting the public health emergency last year, carried over 16 million lives. And we knew one of the biggest things we had to do was knowing how to reach our members who probably moved across the 3 years during the public health emergency, where we may not be able to find them, meaning that their renewal packets may get to the wrong address. And in turn, what's going to happen is we will disenroll you from the Medicaid program. And we, as policymakers, going into this big feat, knew that we need to maintain that continuity of coverage for our members. That is ultimately the top priority for us. So, but we need to make sure people know that the redetermination requirement it's coming back. Our members that have been on the program know about this requirement, but probably need a refresher on what their responsibilities are when that packet comes their way. And we had new members during the 3 years during the pandemic. California grew from about 12.9 million lives, the caseload that we carried in 2020, to close to 16 million. We added quite a few people into our program in those 3 years. So we knew there are a lot of new people that are in our programs that don't know about this requirement. So we worked with an outreach vendor to develop these graphics, really fusing a lot of the 10 actionable recommendations in that brief that was developed for the department. And here you see, we actually went out and tested a lot of the messaging that you see on this slide with our members during during the kind of the preparatory period before we actually started a lot of the outreach. This whole unwinding process took 12 months just due to the breadth and scale of the work that we had to do. And again, California had quite a few people. We had 16 million people, and every month we had a little over 1 million people that need to actually potentially take action on this work. In California, what we did was kind of understanding that the program itself, the renewal packet is very dense. There's many pages to it. There's lots of terminology that may not be as understandable. And those things take time to iterate and change. But what we can do is when we do have these campaigns, to make it simple. An example is we chose to use a yellow envelope to designate all our renewal packets. Used to be sent out in a very a white envelope. And now with this campaign during the unwinding, we wanted to make sure it caught the attention of our members that once they know there's a yellow envelope in the mail, make sure you open it because it's probably from the Medi-Cal program. We tested the graphics here. You see a family holding an umbrella. We actually went and did many focus groups across the state of California leading up to June of 2023, wanting to test certain graphics and colors to see what made sense and resonated with our members. And many of them talked about the idea of a family, the importance of being covered and being very succinct in our messaging. And also, we also tested out the Medi-Cal logo. In California, we have a state oversight and a local county administered program, meaning that many of our correspondence is sent out by our county social services agencies, such as Los Angeles County will send out Medi-Cal correspondence on behalf of the state. Many of them don't understand the difference between Department of Healthcare Services based in Sacramento, California, or Los Angeles County. But what they recognize is the Medi-Cal logo. And in California, the Medi-Cal logo, as you can see, we redesigned it. It's a poppy flower. They know what this is because it's on their Medi-Cal card. So we really took that to heart and made sure from that perspective, that's appended and is on all our correspondence throughout the unwinding. We did ads across the state, whether it be at pharmacies, at grocery stores. We even did videos, made toolkits for our people in the community, our community-based organizations, as well as our health plans. So we really took one consistent messaging guide that we developed at the state, used it, customized it with their respective kind of logos from their organizations and pushed out that very consistent messaging across the state. And it was a very deliberate strategy in the sense we wanted to make sure that we were speaking as a program with one voice. And that's super important. Using the same words on the piece of paper consistently across all the various actors in the ecosystem that do impact the member experience. That was super important for us. And with this outreach strategy, what we actually saw was one of the highest coverage retention rates in the nation for California. And I included some of this here, this information. Our auto renewal rate, which is a vital policy vehicle for us to ensure our members are retained in coverage, went from a 33%, meaning that out of 1 million people every month, about 33% of people will be auto-renewed, meaning they probably don't need to go through the packet process because we were able to verify your information on the back end. But because of lots of like policies that we were able to implement, coupled with this outreach campaign that fused a lot of these great recommendations on really kind of leveraging how to speak to a member, these very actionable steps, we were able to increase a lot of these auto renewals as well as just people being retained in coverage by, with these large percentages. And through the disenrollment period, in totality, approximately about 2 million individuals were disenrolled during the process. We thought on the Medi-Cal for California, we would have lost quite a few people in the program, going back to about the 12.9, 12.5 million levels during pre-COVID at the end of the unwinding. As we stand today, the COVID-19 or the continuous coverage unwinding period actually ended for California on May 31st of 2024. And instead of going back to the pre-COVID levels, we are still close to a little under 15 million individuals in our program, which really talks about a lot of the aggregate success of the work that we were able to do, not only because we were able to reach the member, next slide, please, and also coupled with some of the different policy flexibilities we were able to do. And the next few slides just showcase some of the graphics that we developed specifically for this effort. And one of my panelists here, fellow panelists, talked a lot about kind of the functional areas of health literacy and then the cultural relevance part. And I love the way she described it, because in California, from a functional perspective, we have 19 threshold languages in Medi-Cal, meaning we translate all these materials that you see here on the screen to 19 different languages, in addition to alternative formats, because that's very important from an LEP perspective, and just making sure that, you know, we are talking to you in what you prefer. We collect this information through the Medi-Cal application. And we make sure all the correspondence that you receive, whether it be online through the snail mail, is coming to you in this way. And all these different types of graphics, we offer them through the Department of Healthcare Services page, where our external partners, members of the public, could download them, append them, depending on the threshold language that they would like to pull down, into those very specific in that specific language. The cultural relevance part is also important, because we are not just speaking to one demographic. A state of California being so diverse, we make sure that, you know, we are talking to different audiences. So when developing, using the unwinding as an example, we've developed kind of toolkits for very specific groups. Managed care plans could pull this out, our tribal partners, also for the audiences, such as for folks heading back to school, for parents who have kids on the Medi-Cal program that needs coverage. So these graphics, I think, highlight some of the just kind of the combination of those strategies that we were able to utilize in the state of California. Next slide, please. And just kind of continuing on that theme, just looking at some additional kind of social media as well as graphics. All these different things were tested. And as you can see throughout most of these graphics and things that we were able to do, you see the little yellow envelope. There are pregnant individuals on these graphics. You want to look at a graphic and be able to identify that, you know, I look like that person in this ad. That was so important as we were kind of thinking about how to really kind of promote literacy, not just from a reading and comprehension perspective, but also from that cultural relevance standpoint. Next slide, please. And we even created videos because not everybody understands or reacts to information or receives information the same way. So, you know, we have YouTube videos, and we made sure those were in different segments in terms of the seconds, because, you know, people now have short attention spans. So, you know, 15 seconds, 30 seconds, all the top things you need to know. And these are for our providers who can play them in their waiting rooms as our members are waiting, or just we have some of these actually played on like Spotify, Hulu, and that type of thing. And it really all together, I think, speaks to us as a government agency, really trying to take a lot of the lessons learned from the unwinding and fusing it with some of the recommendations that we have, you know, heard from the community. And it's so important as we, from a government perspective, to look at this work with intentionality and really knowing the people we serve is our Medi-Cal members. It needs to make sense to them, or else we cannot have a program. So those are my closing comments, and happy to take any questions. I'm going to turn it back to Vicky. Thanks, everybody.
Thank you, Yingja, and thank you to all of our panelists. I hope you have noticed all of the reactions and love you're getting We've also received a lot of questions. So I want to kick it off by inviting all of our panelists to come back on video. And I'll start with a question for Yingzhe. How does California collaborate with health plans and community organizations to promote health literacy among members and providers?
Thank you for your question. So for us, as we're transforming the Medi-Cal program on a go-forward basis, we kind of take on various opportunities. So in 2024, we had a new managed care contract. In California, we are a 99% managed care state. So the managed care, just from terms of the contract and kind of how we are moving and transforming our delivery systems are so important. So we made sure a lot of these health literacy kind of components, like requiring the health plans to develop materials that are at the 6th grade reading level, which is goes back to the functional component, in all Medi-Cal threshold languages, and also encouraging, because I think all health plans have an advisory group where they are able to also get feedback, direct feedback from the members. It's all in the managed care contracts for 2024. And so we're kind of infusing a lot of this into these actual documents as actual requirements on a go-forward basis. And for a lot of our health organizations, we do have grants, health navigator grants with a lot of our partners out in the community. Clinics being one, federally qualified health clinics are one where they do receive dollars from the state. And as part of encouraging a lot of this work, we really try to push them as they're developing to use the materials we have already developed at the state, because then they will disseminate very consistent messaging. So from that front, those are the kind of the two pieces where we're really trying to push and elevate the importance of health literacy for the Medi-Cal program.
Thank you, Yingzhe. I'll come back to you with another question in a few minutes, but I want to ask Danielle a follow-up question. And you mentioned this throughout your presentation, but we're really interested in hearing about how you work across divisions and departments within the plan to ensure that your communications are culturally and linguistically appropriate for your diverse multi-state populations.
Divisions, so I wouldn't call them divisions, but understand, because it can be difficult, I'll take one market example, there can be up to 20 different departments with different spaces. So actually what we do have at each market level is we have a standing, we call it a HEAT class program. It's a health equity and class committee. It meets no less than quarterly, and that's for the big meetings, but there are smaller working groups that kind of feed up to those meetings. And in those meetings, there are all the stakeholder departments, leadership, as well as functional associates. And I don't mean that in a bad way. I think oftentimes things get stuck in leadership levels. So it's really important to have those on the ground that are actually working with the member-facing teams, also involved in this work. But during those meetings, we actually present on not only the service area that we work in, but so we kind of look at it in 3 rungs, if I could do like a Venn diagram, or maybe like a little nesting doll almost. So like the big nesting doll is our service area, meaning these may not be all the people that we serve in our plan, but this is what people speak in this area, in this state, in this service area. Then we look at data that's actually from our members. So we collect self-reported data, and we do it on a consistent basis every 3 years or so for individuals' language needs. And so we look at that and we break it down. Then we also look at what people are asking for from a service standpoint. So translations, interpretations, requests for bilingual associates. That tells us more about the functional, not just what people are requesting, but what people are using. And with all those stakeholders in the room, we talk about that. So we operate on a threshold model that can be it's 5% or 200, whatever is less. So if we see a group of 200 languages, we know that that's a threshold. 5% is an absolute threshold. And then we work very diligently to look at communications. A best example of that is if we're articulating some sort of project. So maybe we need to ensure that people really have access to blood pressure testing or blood pressure equipment. So we'll take it end to end and we'll say, okay, this is what our service level looks at. These are the communication ways. This is what is needed. This is how we're choosing to communicate, and really kind of work at that through like almost a member journey to trace out those spaces and where that actual not only limited English proficiency or language access needs are, but also those health literacy touch points. And everything we do is at minimum of 6th grade level. I hope that answered the question.
Yes, certainly answered it and generated additional follow-ups I'd like to ask. But one of them from your presentation, and I'm sure others are sharing this thought, is you spoke of creating an environment where language is considered a component of whole person care. That really stood out to me. So I would just love to hear, in the vein of collaborating across many different markets, what has been a key learning of how to infuse this viewpoint across departments?
Yeah, I find storytelling really, really important, and voice of the member really important. I can raise as much as I want to raise. I can bang at drums as much as I want to raise. But there's a lot of different ways of talking about it. So one is storytelling. It's quite honestly, do you want this to work? Okay. All right, good. We've agreed we want this to work. Okay. But also, we don't all speak the same language. We don't all consume information in the same ways. We don't all communicate in the same ways. Some people are not as extroverted as other people. And so it's really kind of coming to, it's really about, are you trying to accomplish it? You cannot ignore that elephant in the room. It's a reality of life and where we live and how we work. So that message is really important. I think also articulating the flip side of, if you do not have these services, what happens? And you can tie that, depending on your audience, to a lot of different things. If you participate in the health equity accreditation, that's one of the foundational factors. Everybody has a contract. I guarantee in that contract, there's information about language provisions. People usually look at HEDIS and CAP scores. They're governed by that with star plan ratings. So there's that business argument. There's that contract argument. Then there's that empathetic argument. And then there's the reality argument. You can do whatever you want, but you're only going to be hitting so many people. And so I think it really matters how you discuss this. I think all points are critical and salient. But what I try to do in my practice is really emphasize that equity often, sometimes in my perspective, gets lost. Sometimes it feels like a nice hug, but it's a reality. And if you're truly trying to support your communities, you have to look at that centrically. And communication, we know, is one of the biggest barriers, not just for individuals in terms of language access, but being able to advocate for yourself is critical. And so it's just really about that messaging component. And the other flip side of using that too is talk to your stakeholders. Everybody has a goal. And sometimes it's about spelling out these things, and it's not purposeful for stakeholders to ignore it. Sometimes that may not be a part of your reality in life. So again, it's about that storytelling. It's about creating that business case. It's about showing that compliance and really the results, because the results speak for themselves.
Thank you. Really appreciate that. And on the note of centering member voice, I'd like to go over to Isabel and Colleen. But starting with Isabel, what are some of the most common barriers you see members facing when trying to understand and use health information provided by Medicaid?
Thank you. So I don't know if I'm going to answer this question the right way, but one of the biggest barriers that I do see is a lot of times the members they just don't know how to navigate when they go onto the website. They don't want to do it. It's like just intimidating, and I can relate to that as well, because I'm not computer savvy. So that's one of the barriers. So I would always offer them, if they like to go over some slides that show what the services offer. I do that one-on-one with them, so that way I can break it down to them in an easier way. slides and panels. I mean, everybody's doing an excellent job in breaking down these little barriers, but for the most part, right now, that what I see is just getting on a computer and accessing those services in a simple way. And I really like what Colleen was saying about maybe providing a little member handbook. You know, they love the slides. They love the slides in simple terms, providing a little handbook of everything that their service, that their benefits have, and just break it down in simple terms. Thank you.
Thank you,
I
Isabel.
hope I answered that
Talked
right.
about, oh yes, absolutely. Talked about some of the barriers and also gave us some solutions. And I have no doubt that it's also that personal touch that you add by going through things with members that helps. So for both of you, I'd love to ask, can you both share, Colleen and Isabel, what topics the Banner Member Advisory Board or Health Equity and Health Literacy committees that you mentioned, what kind of topics do they focus on when it comes to health literacy?
Do you want me to go first, Isabel?
Well, what the topic of the health and wellness, that was a big issue. That's something that it had their full attention. They were a little hesitant to ask questions because they're a little intimidated, but that's where I come in and I'm able to ask the questions and encourage them and promote them to actively engage. And once they realize that their voices are being heard, that's when they go in and they start asking more questions. So the health for health and wellness, yes. The preventative care also is something that they like to hear about, as well as housing.
Yeah, I would echo what Isabel said. What we try to do annually through through a survey, but also regularly throughout the month, and we do that directly with Isabel. A check-in is, how's it going? How are we doing? What is it that you want to hear about? So this year we focused on housing. So we brought not only plan folks in, but our Medicaid partners as well. We have a lot of initiatives going on through CMS that are trickling down that get put out to our community. And whenever you say housing, they go, oh, right? Because everyone needs shelter. And so there's a lot of confusion that we have to clear up. And we really like to use our committees and councils to do that. So housing is a hot one. Oral health, like we spoke about initially, was, and Isabel is so humble. So Isabel, over the last 2.5 years, we've been working on a restorative oral health project. Isabel went out and interviewed some of our federally qualified health center partners. This is all because they said we're struggling to get sustained employment, and we want to have an open conversation, right? And we want to remove the stigma. And she did project management. She did a cost analysis. She presented it to the plan. We struggled with budget for a couple of years. We have now a full-time oral health director who is swiftly taking that project plan that Isabel created, and Smiles for Life is the project. And it is actually reigniting getting courted across our Tucson, Pima County area, as well as our Yuma area where Isabel is. And we're figuring that this is the first time she probably has actually heard about it. So poof, there you go. There's a little gift, Isabel. But I think it's incredibly member driven. So the topics that we talk about are things that folks, they want to hear about, but they're not let off the hook either. This is a working committee. These folks, Vicki, like we always talk about, right? This is experts by experience, and they come, their input is valued. There is a stipend, an incentive that's attached to it, and they do work, and they have homework. They work from work plans and project plans, and it's all motivated by what they want to hear. But also simultaneously, we're giving them information so they understand what they've shared and how it's impacted our strategic our strategy and our decision making. So I think that we're doing some pretty fabulous work. I want to give Danielle a shout out too. I think it's incredibly important what she spoke about as far as language. So there's that reading and writing and comprehending, but in the language access as far as interpretive services. But what if you're an individual who, and we experience this a lot in our plan, that may have side effects as a result of being in recovery from substance misuse. And so their cognitive capacities are different now, but they want to participate. They want to have their lived experience, really, quite honestly, from a preventative standpoint. So it's not only can you access it from the language, it's the communication approach, chunking information, checking in and regularly creating that safe environment to say, how you going with that information? And is there anything else that we need to do to make sure that you have everything, making informed decision and participating? And then the other piece that Isabel, and I'll close on this, lastly talked about was system navigation. I think that's paramount. Our system is incredibly complex. We have huge member handbooks that nobody uses. 2% of our population uses our member handbook. So how can we but our social media is heavily used. So how can we create multimedia that's accessible in small chunks that they can go back, watch videos on, or get it transmitted into words and revisited. So those are some things that we're focusing on. And that, again, it all comes from the member voice.
Thank you both. Appreciate that. So I'd like to ask a question now to all of our panelists. Just feel free to jump in as you feel called and reply to each other as well. But what role do you see the community health workforce or community health workers and others in the community-based workforce playing in health literacy role? And how can states, plans, and providers invest in a multilingual health literacy workforce?
Kick us off. So that's a great question. Community health workers is now part of the Medi-Cal benefit in California since about 2 years ago. And they are truly our messengers in the community. It's so important to get their buy-in on kind of the correspondence that we use, the language we use, because they will be the external facing kind of individuals for our program. So we have made a very clear investment in, making sure that this community health workers are part of the Medi-Cal program. They are reimbursed for their services, and also kind of instilling of kind of those values that we have for our program, meaning that we want them to be the people that can actually connect with our members, because I stressed a lot about the member experience. And we really are trying to, in California, really transform the member experience with these various actors in the community. And so that's very important to us.
I guess I'm off mute, so I'll go next. I do agree quite a bit of what you said. I think the phrase that you use, I think, is very interesting, is invest. Because I'm very cognizant about power structure. I'm also cognizant about capacity, and I'm also cognizant about barriers to entry. So for those that are, so yes, your community is your heart. Nothing can tarnish a trusted relationship like a rumor. It's like high school. If they hear that something is being treated, if you heard from your best friend that don't go over here because X, Y, and Z, that's it. That's the rest, right? So I think one important thing is to really view community assets as equal. I think I see a lot of models where there is that one-time investment, one-time use, but really think about building that relationship as a practice, as a continuation, and what that reciprocity could look like. So I love hearing just about the stipends and the investments, but the next steps of how they can be used. One of the things that we've instituted as a practice is a CBO network. And so we are intentionally working with our CBOs to figure out what they need and how we respond and how we become better partners to them, rather than always asking them to come over here as well. So they're a critical workforce. But again, I stress that reciprocity. A lot of community organizations are struggling with, resources, technical assistance issues. So really think about those opportunities to solidify those factors as well. And then also think about, as you work with them, what that really looks like to honor that voice and to learn and improve. And so it's really important to make sure that your governance model also is bought into this work, that's respected and acted upon. But they're the heart of everything. That's it. They have more power than we do. So that's it.
I don't really know if I have anything else to add, Danielle. It's like, I don't know, we might be even on the same like vibration, because everything that you're saying, I'm like, victory, victory. Perhaps the only thing that I might add when Danielle talks about reciprocity is we have to be incredibly mindful. It's very sensitive when you bring the community together. You have community conversations, you have networks like Danielle was speaking about. But the whole structure of the community health worker model is incredibly intimate into their neighborhood or their community, and entrusting that and then I don't know, operationalizing that, if you will, in a managed care service environment takes a lot of delicacy, sensitivity, just honor and acknowledgement, and it is bi-directional. So if you're going to employ, empower, create networks, we must be bi-directional in that relationship and honor that. In the state of Arizona, we have really robust community service agency network, which is more peer support, family support. The community health worker model just got Medicaid approval in the development of that. And now as a state, we're looking at, oh my goodness, how do they work in parallel and how can they complement, with community health worker really sitting in our primary care space. And so how do you bridge that also if you have someone who is a champion within a community that is supporting maybe women around mammogram health, but also identifying that maybe within their family systems, they're struggling with mental health needs, which hasn't necessarily sat in that scope, if you will, of a community health worker. But how do you mobilize that and be responsive to it as a community? And again, with that respect and bringing that in. So I feel like there's a tremendous amount of opportunity around the community health worker representative model, creating those Medicaid reimbursed structures for the like I guess more of a robust implementation, but having to do it really, really deliberately and intentionally.
And may I just add on to, because we are vibing, for lack of better terminology, equity is not a quick fix. It took us 400 years to get here. So I always want to impart on people that you need to think long-term within your short-term planning. So you can't build a friendship in a day. If you can, I don't know if I would trust that person very much, right? In the same way as you build those community sources, it takes intentionality, as Colleen has stated. It takes personal touch, as Isabel does. It takes going into those communities and building that network, as Yingja does. But you have to think about what is your long-term approach. And also, I would really love some barriers to entry conversations. This is more a policy consideration, but as I watch like the doula model really being taken up by health systems, there's now barriers to entry in a lot of markets. So now it's a homegrown organic system that now has 2 or 3 years of certificate. So as we're looking at this as well, I really want to also think about that sensitivity of creating barriers to entry, where we see those community models being looked at and worked, and now all these rules happen. So just think about as you operationalize and what that must be like for that community member or that community worker or that organization, and come knowledgeable. But equity is a marathon, and it means working in intention in each step.
Absolutely. Thank you for those comments, all of the panelists. I think we got many questions, but I think one that I'd like to lift up as perhaps our final question for discussion here was from an audience member. So they asked, can panelists speak to language access and literacy for deaf and hard of hearing communities? So I open that up for anyone who would like to jump in.
I know for us at Banner, from a plan perspective, it's all rooted in partnership. So we have it's actually a smaller demographic or population across our 10 counties, but I should say it, but that does not drive priority. We do it because of our approach is to partner with our Association of the Deaf and Hard of Hearing, and they have community health worker, they have peer supports, they have education. So not only is it making language accessible and making sure that we have those supportive services, whether that's ASL, if that's, you know, our translation line, if that's an individual accompanying somebody, but we also bring them in to educate, to help inform. The culture within the deaf and hard of hearing community is so intimate that I know that I've spent like probably the last 5 years developing my relationship with them and building the trust and working on things like enhancing our language services component to meet those needs. Lots of breakdown at points of care that we've had opportunities to enhance. And then the other piece that we're doing is attempting to regularly recruit someone from the community to sit on our committee, so that that voice isn't necessarily coming from me or others on their behalf, but truly from the community.
I'll tag on to that. I think yes to everything Colleen said. For us, you know, one thing that we've noticed is there's actually a lack of resources for that supportive service. So when we do use interpretation services, it's through a vendor. It's very important to know there's a two-part. You need two interpreters. It's not just one interpreter, you need two interpreters. But it's actually a lagging resource. I don't know how to phrase it, but there are not enough interpreters for the need. There's also the situation where there's different dialects. So ASL is the most known one, but there is like an African American specific dialect. There are other dialects for communities that are more insular that may have not been properly trained. And so it is a very complicated issue that I think there needs to be more education on. So we use an interpreter. We do have other communication assisted devices when folks are out on the field. I think there also needs to be a lot of training involved in that, especially when we're thinking about building trust. So one example where there's a very natural way of people communicating. So you typically will talk to the person that's talking to you. When you're working with the population and using an interpreter, your eyes need to be on the person that's actually interpreting through. And that's also with other language access needs. So I think there needs to be a lot more investment in resources for supportive translation opportunities or interpretation opportunities. I apologize. There also needs to be training for providers and other folks that are interacting with interpreters, not just in the ASL or for the hard and deaf of hearing community, but to really have that practice of you actually making eye contact and speaking directly to the person, even though there may be a two-part translation over here. And so I definitely advocate for more supportive services, but it's difficult because you need two individuals to translate. And most companies do have resource limitations, especially in some parts of this country.
And I'll wrap up with what we do for California Medicaid. So on our, we actually just got approval from CMS to update our Medi-Cal application, and on it, it's, you know, asks about alternative formats. And one of the formats available to our members is CDs. And of course, we always support a TTY line as an alternative for individuals. And I think just it is a fundamental requirement across the state for the program for our counties as well well as our Office of Civil Rights to also offer the accessibility option for ASL and speech and hearing impairment individuals. So I think just kind of grounding that kind of infrastructure from a program perspective to have that support and requirement. And of course, in terms of its operations, I think it really will require considerable kind of government oversight in terms of making sure that this is actually disseminated and, folks are getting what they need in terms of accessibility.
Fantastic. Well, we have arrived at the end of this webinar. It really flew by for me, and I really appreciate and want to express CHCS's gratitude for all of our panelists, Isabel, Colleen, Danielle, and Yingja. Thank you for sharing lessons learned. Again, the slides and the recording will be available at chcs.org. I want to thank the attendees for joining and for submitting your questions, and remind you to please complete the survey. Let us know what went well and what else you'd like to hear about, and also what we could improve. So thank you all. Have a great rest of your day, and thanks for the terrific conversation.